seniors, teachers and colleagues. I am with the side of empagliflozin in this small debate. Will I switch over to empagliflozin? We all know that almost 37 companies with more than 200 products have bombarded your OP once the patent of empagliflozin got over. Is there any real difference between these molecules justifying the hype? That is the question. We'll look at these headings, pharmacokinetics and trials and the safety outcome, to decide whether we will switch over to empagliflozin. So starting with the pharmacokinetics of SGLT2, if you look at empagliflozin, it has got the maximum SGLT2 selectivity among the glifosins. Along with the low lipophilicity and the tissue distribution, it acts primarily on the organ it is meant to act, that is the PCT of kidney. So it has less side effects and it produces more superior glucometabolic benefits, as like reduction in HbA1c, reduction in fasting blood glucose, weight loss and systolic BP. This is the theory part. Whether this has been converted to practical data, we will go through the trials. The first group is the cardiovascular outcome trials, whether when the patients have diabetes and established atherosclerotic cardiovascular disease or high risk cardiovascular risk, we will look into the CVOT trials. We know that the flag bearer of CVOT trials is the EMPA-REG outcome, which used empagliflozin in patients with diabetes and established atherosclerotic cardiovascular disease. Almost 7,000 patients were followed up for 3 years and looked upon the 3-point major adverse cardiac event that included cardiovascular death, non-fatal MI and non-fatal stroke. It has been shown that there was 14% relative risk reduction in 3-point major adverse cardiac events, and this is mainly driven by the reduction in cardiovascular death. If you look at the reduction in percentage, there was about 38% relative risk reduction in cardiovascular death. If you take the Asian subgroup, in this group, there was additional 56% relative risk reduction. And this risk reduction of 38% have come from the hard endpoints like reduction in fatal MI, fatal stroke, sudden death and presumed sudden death, and more from heart failure related death. So when you compare this with a CVOT of dapagliflozin, that is declared MI, even though it produced a composite reduction of heart failure and cardiovascular death, the major adverse cardiac event didn't offer as much significance as we got found out in EMPA-REG outcome. This has prompted all the guidelines to include empagliflozin under the heading of reduction of major adverse cardiac event. This is the recent ADA guidelines 2025. If you look at the column of effect on major adverse cardiac event, you can see that only canagliflozin and empagliflozin is included in the column of reduction on major adverse cardiac events. But if you look at heart failure and progression of kidney, both EMPA and DAPA are included. So we'll go on to the heart failure trials, whether is there any difference between EMPA and DAPA. If you look at the heart failure trials, we know that the EMPEROR reduced and the EMPEROR preserved is the main empagliflozin trial, which almost looked at 10,000 patients, and they looked at the time to first cardiovascular death or heart failure hospitalization in heart failure patient. And EMPA has shown that in all group of heart failure, whether it is a low ejection fraction, high ejection fraction or a medium range ejection fraction, it has shown a high relative risk reduction of heart failure hospitalization and cardiovascular death. What does it mean? If you look at the heart failure with reduced ejection fraction alone, the recent trials like DAPA heart failure, the paradigm heart failure which used the ARNI, if you look at the rate of reduction of absolute event rate, it was much better for when the empagliflozin was used in EMPEROR reduced. More than that, this has shown that not only the heart failure reduction, but the heart clinical endpoints like the initiation of dialysis, renal death or sustained reduction of eGFR more than 40% was much better when empagliflozin was used compared to DAPA and paradigm heart failure. What is the most important thing that we have learned from this trial? The effects start much earlier. If you use empagliflozin in heart failure with reduced ejection fraction, the effect starts appearing at the end of 12 days. In preserved, it starts appearing at the 18 days. Whereas in DAPA and other glifosine, it usually starts 4 to 8 weeks. This is the most important point to look after when you are prescribing in heart failure treatment. And this has been shown that almost 50% of the heart failure patients have some amount of CKD. And in all the group of CKD patients, whether it is a normoalbuminuric patient or a overt albuminuria of 300 milligram per gram, there is significant heart failure reduction and cardiovascular death. So, is there any data in acute heart failure? There are few studies, one among such is EMPULSE, which show that at the end of 90 days, 36% of the patient had significant clinical benefit when you start empagliflozin early in acute heart failure. So, moving on to CKD trials, we have finished major adverse cardiac events, we have finished heart failure. Let us look into CKD trials. Even the EMBARREG outcome, which is a cardiovascular outcome trial, has shown that the incidence of worsening nephropathy, progression of microalbuminuria or doubling of serocreatinine and initiation of dialysis was reduced by empagliflozin. Is there any heart trial in CKD? One trial is EMBARK kidney, which is the largest and the most inclusive SGLT2 inhibitor trial till date. The importance of this is that it has included a lot of variety of patients, more than that other trials have included. It had 50% diabetic patients, but other 50% were primary kidney diseases or hypertensive renal diseases, and all these group, irrespective of diabetes status or irrespective of GFR, it has shown that there is significant reduction of progression of kidney disease or heart disease. In MI, acute MI patients also, when empagliflozin is initiated, it has shown that the first incidence of heart failure admission has been decreased by empagliflozin, not by other glifosins. Safety outcomes, there is not much difference between the glifosins. If you look at the summary, genital infections was much higher in empagliflozin, but the incidence of UTI was much higher in dapagliflozin. If you look at orthostatic hypertension, there is a slight increase in orthostatic hypertension in empagliflozin group, but it is mostly due to the decongestive or the diuretic effect of empagliflozin. So, in summary, empagliflozin is preferred because of its strong cardiovascular mortality benefit, its wider use in heart failure and the early benefit, the wider and broad range of usability in CKD, the better metabolic outcome and safety profile. Thank you.
Okay, before my time starts, good morning everybody, respected seniors, colleagues, teachers. Thank you Dr. Deepak Nandan for that excellent, persuasive talk on the qualities of empagliflozin. I am sure, similar to my state, everybody in this room is now almost on the verge of switching over to empagliflozin. I would just like to put forth my points. Yeah, so am I switching my patients to empagliflozin? These are a few articles which came over the past few months about empagliflozin. And we know that these are not scientific journals, but this is from the Hindu, the Economic Times. It is obvious that there is a marketing storm around empagliflozin. So as clinicians, should we get caught in this marketing storm, or will we be able to hold ground? How do we answer that question? Now, when we look at the timeline of SGLT2 inhibitors, as it has already been mentioned, in the year 2016, on seeing the name empagliflozin in ESC guidelines for heart failure, I was so enticed. I mean, I really wanted this wonder drug, which had shown a greater benefit in patients with heart failure. However, it was not available at an affordable cost at that point in time. Comes 2021, the guidelines have changed. Dapagliflozin was also given an equivalent status along with empagliflozin. And 2023 focused update, again for patients for CKD and type 2 diabetes mellitus. Both the SGLT2 inhibitors were included in the guidelines. So as the timeline goes, in 2020, as it was already mentioned, dapagliflozin went off patent in India. And now comes 2025, we have started using dapagliflozin and we are perfectly happy with the effects of dapagliflozin. And now empagliflozin goes off patent in India. Should I switch my patients to empagliflozin? As a clinician, how do we answer a question? In this era of evidence-based medicine, we will look at evidence. The best evidence comes from randomized control trials, meta-analysis, and systematic review. This is the largest meta-analysis, not largest, but perhaps the most relevant meta-analysis of 5 randomized control trials using data from DELIVER, Emperor Preserved, DAPA-HF, Emperor Reduced, and Soloist WHF, including nearly 22,000 participants from all the trials, and primary endpoint was the occurrence of the composite of cardiovascular death or hospitalization for heart failure. And it was found that all these beneficial effects were consistently observed across all 5 trials, the trials which used dapagliflozin as well as empagliflozin, and all subgroups examined. So there is no superiority to claim for empagliflozin over dapagliflozin from the meta-analysis of major trials. Now this is another meta-analysis of the impact of SGLT2 inhibitors on kidney outcomes. Around 90,000 participants, SGLT2 inhibitors reduced the risk of kidney disease progression, AKI, cardiovascular death, heart failure hospitalization, again, equivalent efficacy of dapagliflozin and empagliflozin. So looking at a summary of the meta-analysis systematic review of RCT data does not favor one drug over the other. Now coming to real world data, study 1, this is a study which looked at the comparative outcomes of empagliflozin and dapagliflozin in patients with heart failure. This was from a database including around 11,000 patients, and as we can see, empagliflozin was better than dapagliflozin in the primary composite outcome of all-cause mortality or hospitalization. But when we actually look at it, there was no difference in all-cause mortality. The problem, the improvement was in terms of hospitalization. But when we actually look at it, the authors say that cause-specific mortality or hospitalization, the cause for hospitalization could not be determined due to database limitations. So the authors themselves say that their results should not be used as an evidence to include empagliflozin over dapagliflozin in quadruple therapy for heart failure. This is another study from a Korean group which included 72,000 odd patients, 1.5 lakh person years, and this showed that dapagliflozin was marginally better in terms of heart failure related events. So no significant difference in the composite outcome, but heart failure events were definitely improved by dapagliflozin as compared to empagliflozin. This is a head-to-head comparison of real-world data. This is another study of head-to-head comparison of DAPA and EMPA. They found that compared with empagliflozin, dapagliflozin showed similar risk for most, dapagliflozin showed similar risk for most cardiovascular outcomes. Dapagliflozin had a higher risk of heart failure and a lower risk of genital infections. Again, I was on the verge of switching to empagliflozin. But when we looked at the data, it showed that the higher risk of heart failure for dapagliflozin was seen in patients who were given 5 milligrams of dapagliflozin, which is not the guideline directed dose for heart failure. So the relatively higher risk of heart failure hospitalization was driven by a lower dose of dapagliflozin. So the final conclusion of the study is that dapagliflozin 10 milligrams has similar cardiovascular benefits as empagliflozin. This is another study which again looked at the head-to-head comparison of dapagliflozin and empagliflozin. Nearly 70,000 patients from a Korean database. This looked at the risk of incident atrial fibrillation. So dapagliflozin was found to have a significantly lower risk of incident atrial fibrillation, although there was no major difference in heart failure hospitalization or hypoglycemia. So real world data summary, there is no statistically significant advantage of empagliflozin over dapagliflozin. However, dapagliflozin scores marginally better in the studies done in Asian population in terms of heart failure outcomes and incident atrial fibrillation. I have another worry about empagliflozin because the dosage of 10 and 25 milligrams. This is one study, not a sound study, but I would say this study had shown that there was a greater improvement in the surrogate markers with 25 milligrams of empagliflozin. So I'm not very happy about initiating 10 milligrams versus 25 milligrams. So review of evidence, RCT data does not favor empagliflozin over dapagliflozin. Real world data does not show any advantage. Real world data in Asian population has shown favorable outcomes for dapagliflozin over empagliflozin in terms of heart failure outcomes and incident AF. So final verdict, there is no compelling evidence to favor a switch from dapagliflozin to empagliflozin. So I am not switching my patients at the moment from dapagliflozin to empagliflozin, pending better evidence. Thank you.
Thank you, Amal, for that enlightening talk. As is novel is, it's a good tale, but we have to wait for the climax. As he said, the RCTs included all these trials like EMBA, REG and DECLARE TIMI together. But the problem with this is the study demographic profile of the people that has been included in the trial. If you look at EMBA-REG, it is a more enriched population where more patients from the age of 18 years with more established atherosclerotic cardiovascular, almost 99% had atherosclerotic cardiovascular disease, with 75% having coronary artery disease and more % having low GFR included in the trial. So this is a more enriched patient group of population where empagliflozin showed a definite edge over dapagliflozin. And if you look at the columns of the benefits, major adverse cardiac event, cardiovascular death, all-cause mortality, hospitalization for heart failure, and chronic kidney outcomes. In all the columns, empagliflozin has shown benefit, whereas not in the case of dapagliflozin. In EMPEROR-reduced trial also, if you look at the population dynamics, there was 37% high-risk group. The ejection fraction was low, NT-proBNP was high, eGFR was low, and the mean GFR was 62 compared to 66. So and these patients had more ICD, CRT and ARNI usage. So you cannot compare these two trials together in meta-analysis. That is what I want to say. And even with this, it has shown that it causes greater absolute risk reduction and better number needed to treat when you use empagliflozin. There has been comparative outcomes in favor of empagliflozin where all-cause mortality and hospitalization was reduced with empagliflozin. This was a retrospective cohort study of almost 22,000 patients. So if you take in the case of kidney diseases also, in KDIGO risk categories, all the risk categories in all the eGFR and all the albuminuria, empagliflozin has shown a better outcome. In non-diabetic kidney also, it reduces CKD progression and better cardiovascular outcome, strong evidence in non-diabetic kidney also. So in patients with ASCVD and high indicators of CVD, due to EMPA-REG, the preferred SGLT2 by the guidelines is empagliflozin. In heart failure, everything favors, but EMPEROR pool has shown that EMPA should be the preferred, and in CKD, definitely wide range of usability, EMPA should be the first drug. Thank you.